by way of background, too, for the Perinatal Data Committee, I'd like you to realize that while there's any number of different representatives, the majority are people who work in hospitals throughout the state. The whole group has a very vested interest in being able to provide data that is very helpful to hospitals, regardless of size, and we're very, very committed to trying to keep that happening with consistent statewide data. So I think if we want to go on here, we'll get going with the how we selected Ancilla Partners, who is the vendor. As you can see here, on about January 16th of this year, WAPC issued a request for proposal. And a few days after that, we hosted an informational webinar for all of the vendors. It included a section on how we get data in, how we get data out, and then there was also a section on the technical components behind it. Representatives from 4 qualified vendors attended the webinar, and their request for proposals was due February 2nd. In early March, we had a thorough vetting process for all of the proposals. And out of those proposals, the committee selected Ancilla Partners. They are a web design and development firm from Milwaukee, and they specialize in healthcare quality data websites and portals. They've been very collaborative with us, and they do have significant experience with healthcare data in Wisconsin, Minnesota, Memphis, Cincinnati, and Pennsylvania, to name a few. So now I think I'll hand it over to the Ancilla folks.
Okay. We're going to turn things over to Alan Cooper. Alan, you can go ahead.
Can you advance the
Yep.
slides? Thanks.
Great. Not sure how much more I can dive into this, but again, my name is Alan Cooper. I'm one of 3 partners with Ancilla Partners. As stated, we're located in Milwaukee, and the one things I'll just kind of highlight, as has been mentioned, is that this is kind of our bread and butter of what we've been doing for the last 7 years. We've kind of built our firm to basically support healthcare organizations to provide web application tools. So when this opportunity came around to help basically take the current existing tool and be able to support and enhance what currently is a great base, we were pretty excited about the opportunity. The other thing that I'd like to highlight and mention is we do have extensive experience in working with patient-level PHI information. A few of our organizations we work with is actually receiving this type of level of information for their own initiative. So we definitely are quite aware of the sensitivity and the HIPAA compliance that are needed to be able to support this. So that's basically Ancilla, and I'll probably go on to the next slide.
Can I ask you one question, Alan, before we go on?
Yes.
Do you want to talk about your role with the Wisconsin Collaborative for Healthcare Quality and the work you've been doing with them?
Definitely. Yeah, Wisconsin Collaborative was our first client back in 2007, and we basically have built an infrastructure which we call RBS that basically collects and pulls information from basically health systems around Wisconsin and to basically get the most granular data out of EHRs, which are submitted by the hospitals, and then we basically calculate measures and submit for PQRS on behalf of those health systems. So we, again, if anyone is aware of WCHQ, we basically are their IT. We're kind of their backbone of what their organization is.
And that's patient identified, or
Correct.
Yeah, identified data. Okay.
That's correct.
Thanks.
Excuse me. So I just want to give a little bit of a background of kind of how it all kind of started in early 2014 when we started looking into this project and kind of how we came to the conclusion of where we're at today. Basically, our Ancilla's proposal was actually to take Oracle's current system that you guys have built upon and basically transfer it into a different hosting environment, and we were going to support that. So early on, that was our goal. We felt that the platform was robust and it was built quite well. So basically, we've been working with Oracle to see if there's an opportunity to basically transfer these licenses from the current organization and basically take it over. Based on a few months and learning a lot working with Oracle, we've actually determined that the current licenses that have been used basically for the past 10 plus years are considered educational only licenses, and anything that's supposed to have been used related to Oracle for these licenses can only be used for educational entities purposes. And so because of that, they were not willing to obviously transfer an invalid license to a non-educational purposes. Furthermore, we explored just purchasing the licenses outright, leveraging at least the non-for-profit entity status to see if we can get some discounts. And the prices were quite substantial, almost like $500,000 type of substantial for the initial cost, and then annual fees were ranging between $80,000 to $100,000 a year, with basically a 2 to 3% increase year over year. So I think when we started to work through the cost model with the group and the committee, it just seemed like a lot of money and overhead to be spent, especially if you've been using it for 10 plus years. So what Ancilla has proposed to do is, instead of making the hospitals take the burden of this cost, is we're going to transfer basically the database and the application itself into more of an open source environment that will still provide you the application that you're currently using, and in terms of the database, you're not going to know any difference of how it's being stored. There are some things that we will have to modify and tweak that is Oracle proprietary, and some of those things are related to logging and also the customized reporting. And what we've talked to with, or what we've kind of come to a conclusion on, is making the, obviously we have to replace the login identity type of stuff that's required from get-go, and then we're also going to identify the key reports that may have been lost because we're going to move outside of the Oracle environment, again, to try to get that in day one. But the concept, the customized ad hoc report concept, is something that we're going to have to prioritize with, I guess, the committee itself of, is this high enough importance to actually build and emulate something very similar as one of the enhancements. So that's the current plan. You can probably go to the next slide.
This is Lisa. Before we get too much further, I'd like to remind people to use the question pane rather than the chat box in order to ask questions. I believe that's correct, right, Eva?
Yeah, that would be the best way to get your question across, yes. Thanks.
Thank you.
So looking at the fee proposal, based on our new approach, we were able to at least reduce any overhead type of cost. Like I said, the $500,000 cost of Oracle plus the annual cost to actually have an application such as Oracle. But what you're seeing here for cost, what this is kind of where the cost is going basically is for hosting, help desk support, level 1 and 2, and what level 1 and 2 mean basically is level 1 is everyone kind of calls for level 1, and then if if there's an issue or error beyond that first level, then it gets transferred to a level 2 person to actually work out. Also includes annual enhancements and then any administrative overhead to actually work with the committee itself. What we try to do is tier the cost by births a little bit beyond just kind of 2 levels. I believe the current costs were kind of split between small and large, and what we determined that maybe we should spread this a little bit more between 5 levels instead of just 2. And then the other thing I want to mention is that the initial cost, basically the pro rata of 2014, which is the quarter cost, and 2015 and 2016, all those costs remain flat. We're not going to increase any costs at that point. Beginning 2017, 18, 19, what we've talked about is having a possible 2% increase, but have that cap. So based on kind of how the progression of the program is and the costs associated with it, we will kind of determine whether that is necessary or not. The other thing to mention is there's this one-time setup fee, and that setup fee is mainly to convert our current platform of Oracle and push it into the open source environment. And that's where that one-time fee comes around. Finally, you know, one of the things we're asking, because we want to try to meet the threshold of a number of hospitals to sign up, and our target is June 11th, just so we can get started June 15th, since our deadline is mid-September to kind of get everything moved over, migrated, and up and running, is to ask those that are interested, which hopefully it's everyone, to fill out or basically review and sign a letter of intent with a down payment so that we know that you are serious enough to go down this route. And then obviously there's other documentations, you know, whether they're BAs or and what have you that need to be completed. But we knew that it wouldn't be realistic to have all that done within the next two plus weeks. So the letter of intent was a kind of a short-term, quick solution to at least understand who is interested and who is not, so we can at least determine whether we should move forward on June 15th. And to entice that, what we're doing is offering a 10% discount to those that will sign up with a letter of intent with a down payment before or on June 11th. And what this does is basically 2015, 2016, and beyond, your annual cost will actually start with a lower base. So instead of it being, as an example, under 200 births, you know, instead of 1925 as an example, it would really be 1750. So, and then that would be your base for 2016 and 20. And then 2017 would use that base as a whatever the increase ends up being. That's all I have. Anne, let me know if there's anything else you want me to cover.
No, I think that's the bare bones, and we should see if there are any questions perhaps related to this. Just quick questions about understanding the table. We'll talk more about the actual pricing when we get to the end of the presentations. Eva, can you tell if there are any such questions about clarity of the table?
Yeah, it looks like we do have one that has come in. The question, I'll go ahead and relay it. The question is, if our births are right at the 1,000 mark, which cost point would we be charged?
The 1,000.
The 1,000 mark is what she wrote.
We've talked about using a 3-year trailing average, and I guess that's what we'll want to know at the end of the call, if that's what we should do. And then I think once hospitals are locked in, then they're locked in for the term of the contract, which would be 5 years. So if your births went up dramatically, you would still be locked in at that lower fee, maintenance fee. Does that, Alan, does that
Yeah, that makes
sound,
sense to me.
yeah, yeah. We've played through some of these scenarios, but you can tell that we need your input to make sure that we've looked at all the variables.
It looks like
That came in was, is this births or deliveries?
mm-hmm.
I see we did say by births on that thing, but when you set up the table, was it really births or deliveries?
There was from the data that you provided, so if it was deliveries for that data, it's deliveries.
I got to go look at that.
It looks like a follow-up from the person who asked the question about the 1,000 mark. Okay, if we're at so if we're at 1010, we go with the 1,001 to 2,000, and there's a comment that she likes the idea of the locked-in fee.
Right.
Okay.
We were also pretty cognizant and heard loud and clear that division into more than those two categories of 200 and less and over 200 was important to organizations. So we did try to take that into account.
It looks like we have another numbers question here. The question is, we have 2 birthing hospitals. One does 200 per year and another 750 a year. Are we able to pay one fee for both hospitals together?
We figured this as a hospital fee per hospital.
Per hospital fee.
Mm-hmm.
Right. Yeah, hospitals are set up with sort of separate accounts, so it would be per hospital. And I'm hearing back from Mary Ann that Perry data is based on birth records, so it would be probably by birth.
Okay, good. Eva, are there any other questions related to the clarity of the table?
Not to cost or the table. It doesn't look like it.
Okay, then I think we can go on.
Before we do, I just want to mention that we've had a couple of questions about the slides being available after the call, and we will post these on our website for you to share with others in your organization.
We'll post the webinar. We're recording this webinar.
Yes, we are recording it, so we can post the webinar also. Yeah. Yes.
We'll post the slides and the webinar as one, Eva?
Sure. Sounds good. Okay. So, Lisa, what direction do we want to head next?
I think there were no further questions on that, and I did triple verify that the way we broke this based on evidence from births in 2011 around the state, it definitely was births. I think that's the end of the, let's see, what is this? Oh. The question came in, when does this transition occur for this provider? Meaning, I think, Ancilla. And the answer is, if we have the critical mass, we will start working with them on June 15th. The actual cutover, can you refresh? Is that the weekend of September 19th or something like that?
That's correct.
Yes, the weekend of September 19th to 21st would probably be when the cutover would happen.
Or when the cutover would be complete.
Yes, we're going to be working with them behind the scenes starting June 15th, but that's when the cutover would happen. Okay, so I think that's it on that slide, so I think we can transition to the quality information.
And Mary Ann will be presenting that?
Yep. Let me just get Mary Ann ready to go here, Okay, Marianne, you can go ahead.
Okay, it looks like it's unmuted now.
Yep, go ahead.
We can
Somebody
hear
tell
you.
me if you can hear me. Okay.
Yep.
There's a
I'm
lot of
Marianne.
feedback, Marianne.
There's feedback.
Maybe just turn your speaker down just a tad.
Yep. It's down pretty low. Let's see. Okay, can you hear me now?
Yes,
Yeah.
very well.
Can you tell me if you can hear me at this point?
Yes, we can hear you very well.
Okay, good. So I'm Marianne Weiss from Marquette University. I've been chair of the Perinatal Data Committee since the beginning of time or something, for at least the last several years. The group asked me to talk for just a couple minutes about Peridata and the case for quality. We've spent a lot of time over the last many years talking about what Peridata is, and I think what we have come to know is that Peridata has always been first and foremost about using data to support quality monitoring and quality improvement. That's why it was developed in the first place, and that's how it is primarily being used by hospitals. As we've moved into the electronic health record era, what we've all learned is that EHRs are primarily input systems, but the output has been difficult, particularly getting timely output from the EHRs in terms of data for quality improvement in care processes and the link to outcomes. Peridata is set up in many ways primarily as an output system. Certainly it has inputs. We put data into Peridata, Vital Records sends data to Peridata, and it aggregates it in a place where we can extract that data in real time and by anybody in the organization that has been granted access by the organization to the Peridata system. In terms of quality, the real key features of Peridata for quality have a lot to do with the standard reports. And those of you who've been using the system for a while know that there are a number of standard reports in the system that give the statistical information on both deliveries and births in your organizations. We have maternal and newborn statistical reports that we know the majority of hospitals are using on a regular basis for their statistical reporting. We also have a quality indicators report in the system that produces data whenever you need it on specific quality indicators. The checkpoint report is there. There's a disparities report. And many other reports in the system. One of the things we've been talking about as we prepare for the cutover is the need to have at least the important standard reports, the ones that I've listed here, are available early on, because these are important to internal reporting and for external reporting. And so we know that many hospitals are taking the data from the standard reports and using them for their obstetric and pediatric medical committees. We know that hospitals are using some of this information to report to places like Vermont Oxford, or at least to generate the data for reporting to those systems. So that's an important feature of the system. I think the most important part of the system is the real-time monitoring of care processes. So the system allows us to, anytime we have a question about occurrences that are reported in the system, to be able to go in and look in real time based on births that have been put in into the system, what's happening in terms of, for example, inductions and augmentations, other care processes that people may be interested in, certain types of medications that are reported, etc. And what it really allows us to do is think about quality from the perspective of care process and how that links to outcomes. So the ability to be able to look at those care processes and look at birth outcomes, many of which are reported in the standard report modules. We do expect to move forward with recreating the custom reporting, and I think Alan talked about that a little bit. And so that will be prioritized along the way to make sure we are able to get back to that functionality, but the standard reporting mechanism is a key priority for the new system. And I'd be happy to take questions about any issues around quality and quality metrics at this point, or we can do that at the end of the presentation.
So yes, as Marianne said, if anyone has any questions, feel free to type them in now and we'll relay them. I'm not seeing any. Lisa and Ann, unless you're seeing something I'm not, I don't see any questions at this time.
Not on that topic. There's a few other questions.
Should we take those at the end if they don't relate to quality?
Yeah, it looks like it's more reporting stuff at the moment.
Okay. Great. Then I think Lisa Robinson is on next.
Okay.
All right.
Lisa, you can go ahead. Let me advance the slide for you.
Okay, thank you, Ann and Marianne. Marianne, you made a good case for the quality, and I was asked to give a few examples of how we use PERI data here at Aurora Healthcare, and you know, how it affects the return on investment. And like Marianne said, PERI data is being used to improve the transparency of what's happening in the L&D in our nurseries. So if we can improve the quality and the safety for our patients, it pretty much pays for itself, especially if we can avoid 1 or 2 unnecessary admissions to the NICU. Other uses for PERI data have been, at least for us, that it has been the official birth log for the institution. Since I've been here, over 15 years, we've gone through at least 3 or 4 different medical records. So what's nice about it is that it's a longitudinal, standardized electronic birth log that we'll have over time, especially if questions arise when patients come in and ask for information, or if they need to verify something for a loved one or go back to vital statistics. So that's been very useful. It also accurately links mother and infant. We're able to get the given name directly from the mother or the father of the infant, and we're able to put that in the system. That is what is the official name of the baby that's linked to the birth certificate information through vital records. It also is what's put on the Social Security card. And what's important about that is now, even with our EMRs, anybody in the system is able to update a name. But if they don't do so accurately or correctly, we find a lot of duplicates in the system. So again, it helps to accurately identify the mother and the baby based on date of birth. The other nice thing about PERI data is that it's been used as a great communication source from vital records. So anytime there's any edits or updates, the state has been able to provide that information directly back through PERI data, and we have a dashboard to see how we're doing. We're also able to very easily run the standardized reports, as Marianne and Ann had mentioned, and they're very timely. And the best part about them is that they're very accurate, because again, this is the information that's going to the state file record system. So we're able to give it to administration, to the L&D committees and the perinatal committees, so they can make decisions for administrative planning going forward. The other thing that we found helpful with PERI data is that it really is a check and balance system for coded data. So coded data, yes, I mean that can be sent off for various reporting, for pay for performance and pay for reporting. However, is it always accurate? We found that PERI data has helped to validate the codes and to reconcile if there are any differences. And it's been very helpful. In fact, I was actually on an NPIC webinar just a little while ago, and one of the speakers had stated, well, when they were getting their data via the coded data, they were wondering if they were accurately coding the cases correctly. So again, PERI data has been very helpful as a check and balance system for that. Again, as Mary Ann had mentioned, used again for quality reporting and improving patient outcome, whether that be used for lowering the elective delivery rate under 37 weeks, whether it's looking at how many VBACs are occurring, what our breastfeeding rates are. It's very important for some of these initiatives. We're also able to capture problems and risk factors that are documented within the dictated notes that cannot be extrapolated by the EMR. So, you know, my example that I always give is if we have a fetal or an infant death and it's sent for an autopsy. The cause of death is embedded within the dictated pathology verbiage. So we're very able to pull that information. We're also able to pull risk factor information from the prenatal records that are sometimes in handwritten format. So again, it's very useful to combine that information on preconception or the prenatal period to that of the outcome of the baby. So those are some of the uses that we've had within Aurora Healthcare, and if you have any questions, I'd be happy to take them.
So yes, please.
I think the,
go ahead.
The question that seems to come up here from a return on investment and or a quality thing might be, how are you ensuring clean data? Some places struggle with staff compliance selecting truly accurate data on the you know, whether the data entry sheets and then data entry staff entering it appropriately, including all the information.
Well, here at Aurora, I mean, we've had, especially with the ad hoc report writer that has been a module of PERI data, we've been able to create quality data edit reports. So we run those at the end of each month to make sure that when we're looking at certain metrics, all of the data elements are filled in, that they're accurate, and there are no outliers. If there is, we have a cleanup time period of approximately 2 weeks where we go back and we look at everything, we clean it up, and then we run the final report.
Okay.
But it is very important to have more eyes on that data, and whether that be your L&D committees, your quality managers, or your OB managers, but it continually improves the more you use it.
I think that's about all the questions we had specifically on return on investment, but again, you can see that in our perinatal world, there's any number of different reasons why this is important. And I think the rest of the questions will kind of fall in at the end here. So if we can have the next slide, and then who's doing that? Is that me?
Actually, I think it's me. Hi, this is Ann Conway. We wanted to point out what the next steps were and to reinforce why we're taking the time to talk about return on investment, the case for quality. We will have a letter of intent available on the WAPC website by May 27th, so you'll be able to see. It'll be very similar to the letter of commitment that you signed when we developed peridata.net. This letter of intent is, as Alan said, our way of knowing if you are interested, if you are serious about participating in peridata.net going forward, and it will require that minimal down payment that we had on the slide, and we can go back to that slide of the tables if we want to have more discussion about that. by May 28th, we need to have the correct person in each of your hospitals who is the critical contact. That is, we will send the letters of intent as well to the people who we have on our mailing list. We want to make sure that everybody who needs the letter gets the letter. On June 5th, we will hold another webinar, and it's most likely going to be in the morning. We haven't set the exact time yet, approximately 10 o'clock. We will confirm that with you. The purpose of that webinar on June 5th is to make sure that the right people have gotten the letters of intent, to find out what questions there are from hospitals, and to get a sense of what things are going to look like on June 11th. Now, June 11th is a really big day for us because we are going to be counting up the letters of intent and the payments. And if we have a critical mass, we can move forward with a contract with Ancilla and begin work on creating what needs to be done to migrate the data to have it off of the UWM servers by the date that they want it off, which is the 21st of September. So, which is a Sunday, I believe. So we've got a very tight timeline, and we appreciate the difficulties within institutions. Large bureaucracies, I know, are not easy to get forms signed and checks written. We're just asking you to do the best that you can. If you are having problems, we want to know about that before or at least on June 5th. And I would also ask Alan if there's anything he wanted to add right here.
Alan Cooper, I think
Eva, can you unmute Alan?
I'm not able to. He muted himself. There you go, Alan.
Okay.
Sorry, I'm here. I don't. I guess we'll probably have instructions about where these things should be sent, because I don't think we talked about if they're sent to us or sent to you guys. So I'm sure we'll have that instructions on the website, right?
We'll have it on the letter of intent as well.
Okay. Yeah, I don't think anything else.
Okay. Good. Thanks. Then
Okay, and
we can
again,
go on.
the other place the letter of intent is available will be on the WAPC website. Is that correct?
That is correct, and it'll be. There was a question about which website, and it's the WAPC website at www.perinatalweb.org. You go to major initiatives, and there's a major initiative called peridata.net. It'll be under there.
Okay. We do have a related question then. What if we can get the LOI signed, but it takes us longer to cut the check for that initial deposit?
Then I think we need to hear about that on June 5th.
Okay. So see how far we can get and where we're at with that? I think that's all on that part. There's certainly a lot of questions that'll come at the end, but that sounded like a logistics. There was one question, I think it was, what if a hospital doesn't sign up?
In terms of what?
I'm trying to find the question. Yeah, so it just says what happens if a hospital signs up, does not sign up, pardon me. I think the answer is then, A, you will not, after September, you will just get the prior data back and you won't be using the system anymore, right?
Correct.
And number two, if we do not get the critical mass, then, well, then everyone in the state's in a bind, because we'll all get our data back, and that will be that.
And I think the process for getting data back is a little, correct me if I'm wrong, but I thought it was a little more on the hospital's back to actually work with CUPH to get the data. Am I correct?
That probably is because we still have the contract signed. That's who houses the current data that you have. So
Correct. Correct. But if a hospital doesn't sign up for the, we'll call it version 2, peridata.net, then they won't be part of the system going forward.
Correct. Then the question says, how many hospitals do you need to constitute a critical mass?
60%.
Yes, so 60. Okay. I think on the letter of intent it probably says where to send it to. That's what you guys are going to work on. Okay, if we are a system, can we just cut one check to cover all of our hospitals? I'm assuming that LOIs need to be signed for each site. Is that also correct?
That's correct.
Okay, so yes, one check and then just say which ones it's all for. Okay. Right now that seems to be the question specifically related to that. Is there anything else here, or should we do the big question?
Let's do the big question.
Okay, take it away, Eva. I think the next slide just says questions.
Yep.
Some of this, I don't know if Alan or somebody can answer a couple of these. It does say, at what point will the report within the system be available? I think some of this gets at which reports might be available when. A corollary to that is, does that mean that the custom reports will be affected during this cutover, and then also are custom reports must be built centrally and not by the individual user? And I think that one's a double question because we have some custom reports that were built by CUPH that we all use, and then we also have custom reports that individual facilities have. So what type of discussion has happened with regard to how rapidly or not we might have access to getting back to some of this stuff?
I think, this is Alan, I think a lot of that, once that'll probably be our first priority is to figure out what those are. We don't offhand understand what is those priority standard reports and how many are we speaking of to ensure that we can get it done by September. So because of the tight time frame, it's unclear how many will actually be done. I do think, though, is that if there are critical ones that have to be done, maybe there might be a few that may lag on after September. But again, I think as long as we prioritize it, where we get 80% of the most important reports done or something like that, I'm hopeful. If there's another 20%, we can get it on shortly after.
Alan, there are 16 standard reports, and I think one of the things we can have the Perinatal Data Committee do is look at them and set priorities as which are critical, which
great.
might be midterm and which might be long-term.
That'd be great.
Okay.
This is Mary Ann. Alan, the ones that I referred to are going to be some of the key ones.
So there are probably 5 or 6 out of the 16 that will be top priority.
Okay.
Correct.
Okay, and then I think this is Lisa, and certainly I am no IT guru, so I think the SQL, it's going to mean that there will be different ways that we pull data out and are able to use it. Is that correct?
I mean, if it's something that's being pulled from the application at the moment, that should be independent on the backbone of the database. So there shouldn't be any impact on that. But if they're speaking of something that's related to the customized reporting module, you know, again, that's probably something we have to review of whether that's something we can do before go live or something after go live.
Okay. Because the question is, too, we do a lot of custom reports. What will the new database platform be, and what reporting tool will be employed for writing custom reports?
Yeah, I'd say the custom report is a TBD. We don't, I mean, that's considered an enhancement after we get it go live. So I think if we determine that's the high priority of the group, then that's what we'll do is identify. We don't have an identified report writer at the moment.
Okay.
One of the things this is Ann Conway, one of the things that's built into the pricing structure is a way that we can do enhancements each year, but they would be more methodically set. We've got a whole pile of enhancements that are backlog that we're ready to make, but we don't have the programming resources to actually do it. So the change in definitions is one, custom reporting is another, and after the initial migration of the data occurs, then we'll be methodically looking at each of those major enhancements, interfacing with the EHR. Those are all in the queue ready to go, but we'll need to figure out how to pace the improvements so that there are no additional costs to the hospitals. Everything that we've talked about in terms of enhancements are built into the maintenance fees. So it's not like when we were talking about doing an interface with EHRs that we would have to, as CUPH suggested, that we would go to the hospitals and ask for another couple $100,000 to make that happen. This is all built in. There shouldn't be any additional costs.
Okay. Steve?
And I do think that's an important point, that we've had a lot of conversation over the last few years about the linkages to EHRs, and that conversation is part of the planning as we move forward with Ancilla.
Mm-hmm.
Okay, a couple of other questions are basically, do all reports need to be built by Ancilla, or can some of us do it on the fly like we've been doing?
I mean, I'm assuming on the fly is leveraging that custom report module. So again, that would not be something available on September 21st. Again, it comes back to prioritizing the custom report module as something we should be focused on thereafter as an enhancement.
Mm-hmm.
So there probably will be a lag of some sort before we can get into this. As we get closer to the date, we would probably have more information as to what time frames those would be. Again, up until we found out that Oracle was a complete non-starter, we thought we could maybe just do a straight cutover, and that's unfortunately not going to be possible. In the long run, this will probably be a very good thing, but right in the short run, it's going to probably cause a bit of a gap. The data will still be going in, so you'll be able to get it out when it's built, but it may not all able to come out day one.
Well, I mean, what we'll try to do is try to figure out a workaround for the short term.
Okay.
You know, whether it's, you know, providing some type of CSV download of your data based on like a certain date range or whatever, and, you know, at least give you the opportunity to get the data out so you can do what you need to do with it. Again, we'll have to work with the group to determine what that really means, and also prioritize it with just getting the system up. I mean, the one thing that everyone has to recognize that it's a pretty small window we have to basically migrate an Oracle system into a basically go open source. So that's going to be our primary objective, is obviously get the thing over and running, make sure the data is stabilized, make sure the application of itself is actually functioning, and then reports will follow thereafter.
Okay. Thank you. And Alan Williams, who's on the Perinatal Data Committee, did say that to remind everyone that we will have the ability to export our data and build a custom report into, if you have a hospital internal tool such as Excel Access or something like that, if you bring it in and start manipulating it on that side, that's a way to handle it. Another question is, will we still have an interface with the state birth registry?
Yes.
We haven't had, this is Ann Conway, we haven't had any discussions with the state yet. There's been no indication that there'll be any problems. In fact, we just learned, maybe many of you learned, that there is a new registrar. There has been one apparently since last March, so, a year ago March. So we are actually looking forward to talking with the State Vital Records to get them involved early on in the process.
Another question I see is, will the new Peri data be a web-based application like it is currently? And I'm presuming that's for all, you know, the data entry and the app.
It'll be the exact same look. It'll be the same system, just not running on WebLogic Oracle platform.
Okay. I think Ann alluded to it a little bit earlier, but there's a couple questions on EMR. Will there be interfaces between EMR such as Epic or Cerner, and is there an integration planned with Ansela?
Yes. That'll be one of the enhancements that we'll be talking about.
Okay. I think another question that had come in is, well, two things. One that I can answer probably is, is Ansela set up to send stuff straight over to CMS? And the answer to that is, are they approved vendor? The answer is no. Perinatal standing alone is never an approved vendor for CMS. You always have to have a thing that does the full capability to CMS. So this is an adjunct to that, and it can be a very, very useful tool for you in working at getting your data for those things, but it would not go straight through. I believe I'm speaking correctly on that.
I would defer to Mary Ann.
Who seems to have vanished.
Okay.
But that's my understanding is that the reason we haven't pursued it is because you have to have the full package. We don't do meds first. Oh.
Mary Ann's on.
Yeah, I'm back on now. Yeah, Peri, in order to be a vendor, you have to have the full package of all indicators across the hospital. We certainly can't do that.
Okay.
On the positive side, is the feedback gone? On the positive side, Ansela is part of a larger data reporting system. So by working with them, we get the advantage of their experience with the Wisconsin Collaborative for Healthcare Quality. So we might not be able to be a CMS vendor, but associating with Ansela may lead us in new directions that are very positive.
Okay. There's a couple questions now about checkpoint. Will our measures, are we keeping the same measures and are they going straight to checkpoint automatically? The question on the measures is that's always something that WHA and the Perinatal Data Committee collaborate on. And the plan is to still send the stuff straight over to checkpoint. I think there was another. Yeah, and then there was a same story. I don't believe we're changing any of the things about the triangles for what's required for those reporting. That will stay as it's been. And then there's several questions on, you know, will this stuff interface with particular vendors? Is any what had our discussion been on that? I think the idea was to open it up for how it could be designed so that it would interface in a certain language, and then it's more a matter of defining and getting the definitions to do one-to-one matchups.
Maybe Alan could tell us how they use EHRs now with the Wisconsin Collaborative for Healthcare Quality.
Yeah, I mean, right now, there, excuse me, there is no integrating point with Wisconsin Collaborative. Basically, we have a spec that we ask each of the health systems to follow, and then they basically extrapolate their data from their EHRs and then utilize the portal. So there is no direct connect at the moment.
Okay, okay.
Ann, this is Mary Ann. Can I make a comment about that?
Absolutely.
I think where we, can you hear me, Ann?
Yep.
Okay. I think one of the things we need to say is that we are in really good shape for moving forward with the whole interface idea. Peridata has been around long enough, and we've had enough conversation and collaboration on defining the fields in Peridata that many hospitals have moved their documentation to make sure that they can have the documentation they need in their electronic record for submitting to Peridata. So there is already a lot of consistency between how Peridata collects data and what hospitals are doing in their EHR. Do we need to create those interfaces? Yes. But we've done a lot of work over the last 10 years to create a language that everybody is using and a structure that the majority of hospitals in Wisconsin are using.
Okay. One of the questions, somebody had asked a question about technical requirements. Is there anything different to be able to access the new platform, and if so, when might they know about it?
Assuming access means log in or something similar, right?
Probably.
I mean, our intention is to well, as I say, our intention is to emulate, obviously, the login very similar, you know, that they were used to doing.
And I think back in the day when we were using Oracle, you had to have Java, and you know, you had to have a certain specifications on your computer and whatnot. I don't know if they're getting at some of that.
I see. Offhand, you know, we don't like to do anything that is PC, when I say PC, or your computer, we like to remove the computer or the logic out of the computer and have it more driven by the server. So at this point, I don't anticipate there being challenges.
Okay. And then how many people will have access per institution? Is there any limit? I don't think we limit it right now. It's more how many you hand out, isn't it? Would there be some kind of limit to capacity?
I don't think we talked about it, limiting that, and I don't know if you have a thought on that.
Ms. Mary Ann, there's no limit right now in hospitals to how many. It's what the hospitals designate.
Okay. So I guess there's still several kind of questions just around timeline. I think one of them was we will probably set up some kind of a timeline by when you should have information in. For example, we had talked with WHA that for the October 1st quarterly report, we would probably notify you to get that in closer to mid-September so it goes on the current system, because it might not, you know, we just want to assure that that gets in, being too new with the new system there. So we would have that information. And in general, I think some of the other questions is we sometimes do stuff a little later. What happens? I think to the most point that you can get caught up before the cutover, the better. However, as long as you know where you kind of left off after it, you should be able to get stuff in once the new one goes back on. And again, when we talk about going live, it's that weekend in September there. So I'll let any committee members respond if I'm not saying that correctly. The other thing, again, kind of a reiteration, what is the threshold number of hospitals needed to go ahead? It's about 60% of the hospitals. Are we going to do other education? Yes, the data committee will talk about what to anticipate and when, and if there's some functionality changes, then certainly we'd have to set up some more times in which to be able to do that. Ann or Eva, are you seeing other questions that we maybe have not covered?
Eva, do you see any?
Yeah, I'm looking. Let's see. Did we answer the question about, it looks like there's one, have you been working with other states to consider a national database?
Well, yes, as a matter of fact. One of the opportunities that we have working with ANSILA is that they have partners in other states that they're working on projects, and there may be some connections there. We've also talked about making connections with hospitals within systems who are in other states. So there are opportunities right now. First, I mean, we have to set our priorities, and our priority is to have a safe migration of the data to the new platform. To do that, we need to have the letters of intent and the commitment payments, and then after June 11th, we can talk about all the detail. But until we know if we can commit resources to ANSILA, all these other things are great ideas that we have on in the queue, ready to go.
Yes, and again, they're asking what is 60% of the hospitals in Wisconsin, of the hospitals already on board? I would say it's probably of those on board. Now, certainly if someone else who wasn't on board wanted to get on board, that would be great too. So do you guys have a rough number?
60% of the hospitals on PeriData are approximately 60% of the birth hospitals, give or take. So if you look at any of the divisions of births, the 5 categories, it would be 60% of the hospitals in each of those categories, or a total of 60%.
Okay, and then we've got, of course, some of the fiscal year stuff. Will we be able to prorate 2015 fees, or will we be able to, and how can we pay that?
A question that I have is, have hospitals paid their 2014 maintenance fees to UWM?
Well, they should have. You mean that, well, the 9 months, they should have already paid that.
But have hospitals paid it? I know
Well-
the invoices were sent. But I mean, it's May, so my guess is there are hospitals that haven't paid it yet.
Several people are saying they paid the prorated amount to UWM, so several are.
Okay. So I think we have to work that out with Ancilla as to how they want to handle the 2015 fees. From everything I've heard, and Alan, I don't want to put words in your mouth, but you're very reasonable people, and I suspect that you would have some latitude. Is Alan there?
Yeah, I guess I'm just curious what 2015 yeah, I'm here.
Okay.
Can you hear me?
Yeah, I can hear you now.
Okay. 2015, I'm not sure what pro rata really means, I guess, when it's a full year. Are they speaking 2014?
I think they're looking at a number of things here, if I'm looking at it correctly. Number one, the first and foremost question is, I think, when do we have to have different installments in? It sounds like we have to have our good faith, if you will, little deposit in quite soon here.
Mm-hmm.
And then we have, and correct me if I'm wrong, the rest of 2014 plus the 2015 would then need to get paid in. And I guess that's the question that people are asking about. Does it have to be all at one time? Could it be split based on when their fiscal years go or whatever? I think is what
I
they're
see.
asking.
So it's not really pro rata, it's just how we're going to distribute it then. I think what we were thinking is that we'd like to get the 2014 payments in by September, so the remaining basically quarter. Obviously, I think similar to what Ann's, we obviously are flexible based on the fact that people do have different fiscal years. And then we'd like to have 2015 paid by January 1st of 2015. And again, I think if there's circumstances with fiscal years, I think we can deal with those one-on-one.
Okay. And we are going to get that chart back up for the payment.
Mm-hmm.
Yep,
Post-
I was just going to say that, Lisa. Thank you. Let me get that back up.
The question came in, do you know how many hospitals have confirmed that they will be sending in their LOI? Since we're just giving this information now, I would say I don't know. I'm hoping an awful lot of them are going back right now to talk to folks.
We also just had a question about the letter of intent while people are looking at this chart.
Eva, I'm not seeing the chart.
Still says questions.
Oh, I'm sorry. Let me fix that.
There we go.
Okay. Sorry
Thank
about
you.
that. I just wanted to quickly say, we're getting questions about the letter of intent and where it will be on the WAPC website. And Ann, you said that will be available by May 27th. Is that correct?
Mm-hmm.
In the Perry Data section of the WAPC website?
Mm-hmm.
Okay.
Yes.
Thanks.
Okay, and I know there's always challenges that they've not added these additional costs to the fiscal year budget, so it would be challenging to submit the rest of 14 and 15 by 1/1.
Again, I think if we can you know, it's a one-on-one type of basis. We can discuss the circumstances as they see. Obviously, I'm hopeful that not a large majority are going to have it where we're not going to get, you know, funding until like mid-2015. So I think we just have to, again, our goal is to get these things in by those dates, and then, you know, if we have to have the payments split up by a quarter or, you know, a semi-annual, we can work with those one-on-one type of things.
So by the end of 2014, just as an example, a hospital that had somewhere between 1,001 and 2,000 births would pay $3,688. Correct?
Correct.
And then in 2015, assuming that they're part of the group that signed up by June 11th, their maintenance fees would be $6,500 for 2015.
Correct.
Okay.
Okay, and then just as a reminder that for a lot of years here, we probably got more than a bargain on the fees that we were paying, and in fact covered less in FTE and so on over time. So these are somewhat more in line with what's real in 2014 and beyond.
And in fact, they're very comparable to what we had already started talking with UWM CUPH about the next contract that would have started in 2015, and their fees were very similar to these fees, except that we didn't have the 5 different categories of hospitals. We had the 2 categories, but for the larger hospitals, that was a very similar range. So even if we had been able to stay with UWM CUPH, we have been talking about CUPH needing to raise their fees to make this a sustainable program.
Okay, good. Couple other questions. Do we have any, this is sort of an IT question. How long do you anticipate it would take to move the data and stabilize the system?
Before September 21st. I mean, our goal is to get the first month, a month and a half, to get our environment up and running and begin just testing it, and then basically mirroring what you guys currently have to test out the system. So
you would anticipate, though, that when, as I keep calling it a cutover, but whatever that thing is, that it should be fairly stable after that weekend?
yeah, I mean, the goal is basically September 21st or whatever that date is. That's when you would start using this, you know, basically the same system on a different host.
Right.
I mean, our goal is basically you're not going to notice anything different when you log in terms of entering your information and what have you. You may notice the login might be a little bit different, and you obviously will notice that anything related to the customized report module will not be available. Other than that, everything else should appear, you know, the same.
And so then the question said, so downtime will be minimal, and I'm thinking, again, on that one weekend, we probably would put a hold on stuff as it's happening. But you would know about that ahead of time, and that's probably all it would be whatever defined hours that you'd be notified of that it wouldn't be available. That sounds correct?
I mean, we have to, we basically, once we get the system up and running, we'll be testing out what is realistic in terms of a cutover, and depending on the volume of the size, or depending on the size of the database, you know, sometimes databases can basically be cut over within an hour, right? Sometimes it may take longer. So I think once we get into it and we understand a little bit better, we will communicate this out to everyone as soon as possible. And if there needs to be a 1 or 2 day, basically, the system needs to be shut down so we don't have any new data points. We definitely give everyone an opportunity and a heads up far in advance.
Okay, great. Thank you. And there was one question here on are there a proposed timeline for enhancements. I think the only thing I'd say for that right now is I think the data committee would be working very closely with ANSLA as far as we've mentioned before, prioritization to get the basic stuff we need done right now and back going and functioning very well before we'd work on those additional enhancements. However, it's budgeted to be able to do those at a later date, so we'd have to have you stay tuned for when we would be able to tell you when those would occur. Does that sound correct?
Correct.
Okay. And then this is a really good one, and I may defer to Mary Ann because she's always pretty good at this. It says, can you give us 3 main points to present for curbside encounters when asked about this whole issue, like the letter of intent, the payment structure, the plan moving forward?
I'll try. I'll see if I can keep it to 3. Been alive, well, and very active for 10 years now, with lots of benefits to the hospitals that have been using it. We were, in any case, at a time when we were going to have to renegotiate fees. Fees have been extraordinarily low, and I think that key point is important. The fees that we're charging for the new Peridata 2.0 are very reasonable considering what hospitals paid for other data services and registries. So we are more than in line, and in fact lower than most of those. I think the major issue is the benefits that people have accrued from Peridata, and I would say the other point is that many hospitals have not used Peridata to its fullest, and we expect that as we move forward in the next relatively short period of time with trying to deal with the electronic interfaces, that those benefits will become increasingly visible. The one thing that Peridata gives people is quick access to data. We all know how long it's taking to get it out of other systems, and this is a platform that will link varieties of platforms, vital records, EHRs as soon as we can get there, and create a user-friendly output system for the clinical people that need this data to make changes within their clinical environments and report directly out of their clinical environments.
Thank you, Mary Ann. That was relatively concise.
Thank you.
And excellent points, because it's what we've talked about an awful lot in the Perinatal Data Committee. This stuff is hugely important from the perinatal services and outcomes that we work on all the time locally. I think that's about the questions that we had. Again, one more time.
Can we go to the last slide too before we end?
Yeah.
Okay. Go ahead. I'm sorry, I didn't mean to interrupt you.
I was just going to reiterate again when it says things will be available on the website. That's perinatalweb.org, and then under major initiatives, peridata.net. We'll have this recorded, and the letter of intent will be on there next week. I guess we can kind of sum up. I had one more question. Will the system interface with all EMRs? That's probably to be determined on how something is set up. A lot of that's more based on what customization an organization has done, more so than on the language that it's written in. Okay, so Ann, did you want to summarize?
Sure, I can. Lisa's already clarified where the letter of intent will be. It's really important that we have the correct person in each hospital who is our contact. We'll send out notices about important dates, about things that need to be completed, about input we need from you, but we need to have the right person. So if you know someone who didn't get the notice about this webinar, that probably means you're not on our database. Let us know. We can add you to it. The next webinar will be June 5th, and again, we'll send the notice about the time. It's most likely going to be in the morning, but I haven't checked with all the people who need to be there. June 11th, we'll have another, that'll be the due date for the letter of intent, and the commitment payment will be due. By June 15th, we'll know if we have a critical mass and we can begin work. Now, a critical mass is 60% of the hospitals on PERI data, which is approximately 60 birth hospitals, or 60% of the hospitals in each of the different size categories. So the moral of the story is that this is kind of a team effort. There may be say 30% of the hospitals who really want it very, very badly, and we're depending on that 30% to help us get the other 30%. We aren't out there, we staff aren't out there hearing what the questions are. The people on the call, Mary Ann Weiss, Lisa Locken, Lisa Robinson, those are all people who you can go to with questions, and they can field them to us and to Ancilla, or you can contact me directly, conway@perinatalweb.org. So we're looking forward to talking with you on June 5th, and if you have questions in between, please feel free to contact me. Thank you so much for attending. Anything else you want to say, Lisa?
Again, it takes a village. I think we've done so many fine things over the last 10-plus years. I think there's much more great to be done. And is this a time of a little bit of uncertainty and change? Yes, it is. But I think it's a minor speed bump along the way here. And again, the more you can advocate and take this back to the folks who need to sign off on the letters and send the checks, and we'd be very, very grateful. Thank you.
And Ann, one thing, would it be fair to say that if we have critical mass and earlier than 11th, which would be fantastic, I'm sure we'll probably communicate that just so people are aware sooner than
Yes, yes, yes.
You'll see the fireworks go up in the sky, so you'll probably know that that'll be part of your notification.
later.
Yes, absolutely. All right, I think we're good. Anybody else have a last thing to say? Last comments? Hearing none?
Okay.
All right, thanks everybody. We'll talk again soon.